I'll just introduce the rest of the folks on the dais up here. Dr. Daniel Miller, who is the head of the international unit within the Office of Global Health Affairs. Dr. Marie-Paule Kieny, I think probably everyone knows, that head of the Vaccine Initiative at WHO, and Mr. John Monahan, who is the long-term interim director of the Office of Global Health Affairs within HHS. And I believe now we're going to discuss our opening comments for the beginning of the meeting. I'll turn it over to Daniel first. No, Marie-Paule. Sorry. Either way, whatever you want to do, it's fine. Yeah, this statement.
Good morning. It's a pleasure to be here. I would first like to thank the US government for having invited WHO to co-chair this very interesting meeting. And I'm delighted to be with there. So I greet you all on behalf of WHO. I give you Dr. Keiji Fukuda, the special advisor to the DG on influenza, sends his apologies. He wanted to come. Actually, he spent his whole morning in Geneva airport trying to leave. He was due to go through Paris and couldn't make it. So he sends his apologies, and I will give his keynote address instead of him. So it's, I'm very happy to be at this meeting also, because it really also talks about a very, I think, a very successful collaboration that we have had with BARDA at WHO since 2007. And this was before we talked about H1N1 pandemic. This was by the time where avian viruses circulating in some part of the world were really the main source of worry. And we started this program that will be described to you in trying to help build capacity to make influenza vaccine in developing countries. At this time, it was conceptualized by the Global Action Plan to increase supply of influenza vaccine in 2006. And in 2007, BARDA was, and the US government was the first donor to contribute to this plan, and is still the major contributor financially and also technically to this plan. So, of course, in addition to the preparedness that we will discuss and the steps to be better prepared for the next pandemic, we will certainly look at what happened and the lessons learned of what happened during the H1N1 vaccine pandemic. This was certainly for all of you and for me a most interesting experience for the first time to see a pandemic unfold in front of our eyes. We have learned a lot about vaccine supply, about how much can be produced, in how long, about distribution, about equitable distribution. And as certainly you know, governments in donor countries have come forward to try to ensure that the distribution of vaccine will be more equitable than what it would have been otherwise. So we now want to look at what happened during the past month. We want to look also at what needs to be done for the future. Certainly, as you will see in the presentation I will give you my first data on a survey that we just concluded very recently on how much vaccine was produced. And you will see that indeed we are not where we would like to be. And so we will have to reflect on what happened and what is the plan for the future to build an infrastructure for vaccine production, for pandemic vaccine production, taking into consideration also the constraint that demand for seasonal vaccine is posing to all of us, in order to build a better infrastructure and to make sure also that this new infrastructure will be sustainable. So really, I look forward to the discussion. We have been working in our circle and trying to work incrementally, if I may say, one step and then the other step. It's time, I think, and this is why this workshop is really coming at the right time and is really the thing that needed to be done, to look at the big picture and stop, maybe think, what do I do after my next step? To think about where do we want to be in a few years from now, and to try to see what are the conditions that would allow us to be where we want to be in this time. So again, thank you very much to my co-chairs and to the government of the United States for organizing this meeting, and I look forward to the discussion over these next 2.5 days.
It's on. Good morning, and on behalf of the Office of Global Health Affairs in the Department of Health and Human Services, I want to add my welcome. I would also like to speak very briefly about who is in this room. Look around and you'll see many of your colleagues who are working in your fields of expertise in vaccine development, in influenza, but you will also see a wide range of additional stakeholders. We intended to invite representatives from a wide spectrum of potential stakeholders representing ministries of health, ministries of foreign affairs, scientists, academia, WHO, international organization, nonprofit organizations, international development banks, and a wide range. And we did that on purpose because we wanted the ideas from everyone as potential stakeholders of what's missing, what are additional steps for the future, and how can we all better work together to achieve concrete milestones and objectives. The core planning group that we brought together really wanted to make this an interactive and participatory experience. So we did want to keep the group relatively small, even though this is a big room and it appears that there are a lot of people here. In reality, we had requests to attend almost double of what is in this room. But we needed to balance the idea of having a small enough group to be able to actually have dialogue and discussion with each other. And so we have actually structured the next 2.5 days. The first day you will hear a lot of us talking at you, more to give you a sense of the current status of affairs. But the following day and a half is really designed to be short on presentations and long on discussions and dialogue, so that we can capture your excellent ideas and synthesize those into a framework that we can move forward collectively. We actually also had a much smaller room planned for this meeting. So we actually turned away many people for this meeting. And in the 2 days before the meeting, we had another different meeting cancel, so we actually have some extra room, thank goodness. And we actually were able to, at the last minute, be able to begin accommodating some observers to be able to hear what is occurring here. We encourage you strongly to use this opportunity to brainstorm, to share ideas, and to present your ideas with each other and from your microphones. And to continue the discussions not just in this room, but in the hallways during breaks, lunchtime, and after hours. And we really view this as the beginning of a conversation and a dialogue. And we're looking very much forward to the next 2.5 days in the beginning of that dialogue. Thank you.
Thanks, Daniel. If you could put the objective slide back up just real quick. These are actually in your handout, so I'm not going to spend a lot of time on them. Just a couple of comments.
My talk?
Yes, so as Daniel said, today we'll look at the first objective of reviewing the current status and the investments that we have. And one of the things that BARDA is very interested in is ideas coming from this meeting and priorities to look at our international funds that we have annual funding and getting ideas on how we can best use it. And then tomorrow we'll be looking at the gaps in manufacturing to better meet the needs. And then the final day we'll be looking at stakeholders and partners and how we might build a larger framework. That's sort of the objective. The only other comments I have is, yes, please, when you have a comment, introduce yourself. Since we're not going to go through the process of introducing everyone in the room, you have the participants list, but please, when you make a comment, introduce yourself and your affiliation clearly so we can follow up, because we're recording this both by video, and also we have professional note takers to look at what the final product of this will be, which is not decided, but we can tell you for certain that there will be an extensive report, summary, publication coming out of this workshop that will be available to the broader audience. So there will be a product. So now I'll turn it over to Mr. Monahan, who will address this. And please feel free to make a comment.
Thanks. Thank you, Mike. Well, first off, let me just say on behalf of Secretary Sebelius and the whole Department of Health and Human Services, I just want to thank everybody for participating in this workshop and coming together here. As Daniel mentioned, we have a broad cross-section of people here today. I want to make particular notice of Dr. Carrie Ann Jones, who's the Assistant Secretary of State. In addition to her multiple duties, she was just recently designated by Secretary Clinton as the Special Representative for Avian and Pandemic Influenza. So if you see Carrie Ann over there, she's been a terrific colleague. One of the lessons, I think, of this H1N1 experience is the power and the challenge, frankly, of interagency collaboration within the United States government. But I think this is also a huge. We've learned a lot, we've accomplished a lot, and I think we have even more to do together. And so Carrie Ann's been a terrific partner. So thank you. Let me also echo a couple of the points that Dr. Lurie made. I think one of the interesting parts of the experience, at least from where I sit in the Department of Health and Human Services, is this is an opportunity for us with H1N1 to both do lots of good, as has been done, but also to take this opportunity to learn and plan for the future. I don't know. I tend sometimes to make things too personal, but I coach a lot of different sports and have played when I was a kid, and there's no substitute for looking at the film after a game. There's no substitute for looking at your own experience in real time to prepare you for the next game. And I think as a world community, this is an opportunity to think about our playbook and be prepared for the future. And so I think we also ought to keep that in mind even as we continue to work through the complications and the challenges of H1N1. And so with that, though, I think we also, I have the privilege of introducing our keynote speaker, though I'm afraid we have our original keynote speaker is spent several hours in an airport in Geneva, Dr. Fukuda, to try to join us, but we have a far more than able substitute with Dr. Kieny. So I think you all probably have the biographies in your book, but just to let you know, Dr. Marie-Paule Kieny is the director of the WHO Initiative for Vaccine Research, and she's held that position since 2001. The Initiative for Vaccine Research's mandate is to provide a centralized source of leadership, vision, priority setting, and coordination with worldwide vaccine research and development efforts. Dr. Kieny has a long career in vaccine research and development, and she's published more than 250 articles both on this subject and other scientific matters. She's a deeply distinguished scientist. She's someone who's been an incredible leader in this field, and it's our honor to have her be the keynote speaker here. And let me also add that in part this was an experience of my own working with our colleagues at WHO through the H1N1 process. And I would just note that Dr. Kieny's personal commitment, her tireless efforts, and frankly the personal efforts of individuals from the Director General all the way down have been really has been a terrific, been made for terrific partners in what have always are complicated. It's a complicated process, but I think we also have to remember how hard people are working and how much depth of commitment there is. in all the countries of the world that are working to try to address this common global challenge. So with that, let me thank Dr. Kieny for being our last-minute fill-in as keynote speaker, and look forward to your remarks. Thank you.
Thank you very much, John. I don't think I merit all this credit, but I'll do my best to replace KG. Actually, my slides is a mixture of what I, at the last minute, indeed made overnight, and what I found on my computer this morning. So the general aspects are more from KG, and the vaccine aspects, as you may guess, are more from my own input. So how do I get that? So this talk will have two parts. Actually, I first want to update you on the pandemic characteristics and on the public health response so far. And then I would like also to describe to you and to give you an update of the pandemic vaccine deployment, which has been initiated a few months ago and which is really now starting in an active phase. So in terms of where we are now with this pandemic, as of January 3, this is the last dates that I have found on the WHO records, more than 2,008 countries and territories have reported laboratory-confirmed cases of a pandemic virus, and in this at least more than 12,000 deaths. As you know, many countries have stopped, and nearly all countries have stopped actually counting the number of cases because of the mildness of the disease in general. Then the number of cases that we have can be actually is likely to be much lower than what actually happened. And just discussing with some of you in the audience and some other colleagues, I don't know how many friends and people I met, they say, "Oh, I just got flu." So I guess that if it was indeed H1N1, it means that quite a lot of us got it already, the ones who didn't get vaccinated on time. So currently the most active areas of pandemic influenza transmission are in parts of Central, Eastern and Southern Europe, North Africa and South Asia. So this is how the global spread of pandemic H1N1 vaccine, this is one of the types of maps that WHO keeps current on the website. This is also the January 3 slide, so you can see the dots, and the size of the dots depend on the number of deaths reported by country. So you can see that really there has been pandemic influenza death in most parts of the world, with the exception, the notable exception for the timing of sub-Saharan Africa, or at least of many countries in the sub-Saharan Africa region. So, of course, we don't know how this will evolve, and we don't know whether some of these countries, the absence of recorded death is due to the low level of surveillance, and how this will evolve in the coming months. In terms of people most affected, well, as I'm sure many of you know, the age groups between 5 and 49 are the most affected worldwide. The age group distribution of the disease seems to follow the same age pyramid in each country. There's a difference, nevertheless, in the median age between mild, severe cases and fatal cases. Nevertheless, as you know, also the comparison between countries is really difficult also. So here you see that the distribution of confirmed cases by age, and you can see clearly that the age is more towards the younger age. You can see here the age-specific hospitalization rate, and you can see that this is a different age as compared to what we say in overall mild cases. It's with a large number of small children hospitalized. And more or less, when you take all these data together and you summarize what you have in the reports that we're getting in WHO, you can come up with the fact that for laboratory-confirmed cases, we have a median age between 12 and 28. Hospitalized goes towards older age, 20 to 36. Then ICU admission, 36 to 46. And finally, fatal cases tend to be older than mild cases of the disease. As many countries have reported, pregnancy is cause of severity, is the basis of more severe outcomes, and this is certainly one of the reasons why the WHO has recommended pregnant women as one of the target groups for vaccination. In terms of the characteristics of the virus so far, well, the virus is still antigenically similar to the ones that was isolated by the US CDC and was used as a basis of all vaccine available today. Likewise, genetically, the vaccine, of course, is still similar, and there doesn't seem to be any significant difference in the vaccine, in the virus itself, between mild and more severe case. Some occurrence of virus sensitive to oseltamivir has now been reported, but still the overall majority of the viruses still is sensitive to oseltamivir. And finally, as we know, the virus evolution is unpredictable. So we still don't know. Often people come to WHO and say, what can you predict? How will it turn out to be? Will it be more severe? Will there be more cases? Will there be one more peak? Well, the future is unpredictable, as is the evolution of a virus, but certainly we need to be prepared for a change. What is the situation as compared with the prevalence of other influenza viruses? So there has been, and still is in certain parts of the world, a co-circulation of seasonal strains and H5N1 as well as H1N1. And if you can look at this slide, so this slide really summarizes the most recent nature of the influenza viruses which are isolated in the world right now. So of course H5N1, the number of avian virus, the numbers are too small in humans, so it won't show on this slide. But you can see in yellow here the vast majority of the influenza viruses which have been isolated and characterized are of the H1N1 pandemic, although in some region of the world, you can see, for example, in sub-Saharan Africa, you still have a significant quantity of seasonal influenza viruses circulating. So how has this all evolved? Of course, there has been historical and contemporary concerns that have broadly shaped the response to the current influenza pandemic. We all remembered the severity and the disruption caused by the 1918 pandemic. There was also, everybody had in mind the political and the programmatic consequences of the swine flu episode that the US had in 1976. So this also shaped the response. There has been in the recent past a renewed focus on emerging and re-emerging infectious diseases. A rapid, extensive multisectoral impact of SARS that everybody also had in mind, and a fear of the spread, the lethality of the H5N1 avian virus. So all this, as well as an increasing conversion of health and non-health issues with intergovernmental discussion, has really given the framework for the response to the H1N1 pandemic. So such broad concerns before the start of a pandemic have supported significant actions from the international community. So there has been initiation, as you know, of the WHO global influenza surveillance already in the late 40s and the 50s. But since the recent past, there has been really intensified nation preparedness planning, including by the US, who has been a partner on that, caused by the emergence of H5N1. The passage of the international health regulation in 2005 has also provided the international community some tools to prepare and to react to such a pandemic. In terms of vaccine, a significant event has also been the launch in 2006 of a global action plan to increase supplies of pandemic influenza vaccines, which came when the world realized that should there be a pandemic with high lethality, we would have been in 2006 nowhere in terms of providing access to developing countries to pandemic vaccine. And this global action plan was really intended to link the pandemic vaccine with seasonal vaccine and try to expand manufacturing capacity. And also importantly, there has been updated pandemic preparedness guidelines prepared by WHO in 2009, followed by 2005 and 2009. So before the pandemic started, there were many questions related to pandemic vaccine. The first question was how much vaccine could be produced on time? Who would assume liability? We knew already that the industry was worried that deployment in a very short period of time of a vaccine for which limited knowledge would be gained before it can be used would potentially give rise to a lot of trials and suing, and therefore there was a big concern about liability. Another question, how would recipient target group be identified? How would vaccine be delivered? And there was also unresolved question about virus and benefit sharing that was linked to the problem that we had with developing countries decided at one point that they didn't want to share any more viruses with the international community by fear of not getting benefits of what they saw as a significant contribution. And also one other question that was lingering, although rarely spoken of, is would governments nationalize production facility when the crisis would be with us? So when the H1N1 pandemic started, WHO initiated a broad set of actions. So the overall objective of the pandemic response plan of WHO was to mitigate the impact of the pandemic influenza on people and countries. You can see there are 6 particular actions that were decided, that were rationalized, that were discussed with member states in terms of mounting an effective response. And what I will speak the most now is really the one that I know most, is accelerate access to vaccine. But I just want to remind you that this is not the only area of work that the WHO has been pursuing in response to the pandemic. So within the vaccine area, there had been 4 particular priorities. The first one being to facilitate the rapid deployment and manufacture of influenza vaccine, to provide guidance on the use of pandemic vaccine for developing countries, but not only for developing countries, for the whole world, to monitor vaccine safety, and also to open or increase vaccine access for developing and low and middle income countries. So this is where I really want to enter into the second part of my talk, is to describe to you the objective and also the current status of the WHO vaccine deployment initiative. So as I just mentioned, this initiative was brought forward a few months ago to try to ensure access to vaccine for low and middle income countries in need. So this came following a call really from the Director General of the World Health Organization and from the UN Secretary General to international solidarity to meet the donation target of 10% coverage in population in need. Several donor governments and 5 manufacturers have so far pledged support, and since then WHO is directing and coordinating the deployment of donation and provision of technical operational support in collaboration with the UN family, and in particular with UNSIC, with donors and with other stakeholders. Where are we starting from in terms of defining, and where did we come up with a notion that 10% coverage would be something that would be the minimum that we would like to provide to the developing countries? What we want to achieve in terms of deployment and target is really based on the recommendation provided to WHO by the Strategic Advisory Group of Experts, or SAGE, whose chair, Dr. Salisbury, just sitting in front of us, David. So the SAGE is providing overall overarching advice and recommendation to WHO on all matters related to vaccine and immunization. So already on July 7, the SAGE reviewed what was available in terms of evidence and recommended, made initial recommendation on the use of pandemic vaccine. So the first recommendation was that front-line healthcare workers and healthcare workers in general should be immunized as a first priority in order to protect the healthcare system and to allow the healthcare system to continue to function, to care for people with influenza and also to care for people with other ailments. So we estimate this at about 1 or 2% of population. Then the SAGE also reviewed what would be the potential target and took note of the fact that different countries may have different objectives by using influenza vaccine, pandemic vaccine, to reduce or to slow down transmission, to protect essential persons, to protect high-risk group, and has really identified a number of specific groups which could be targeted according to national plans for vaccination. So these include pregnant women, individuals with underlying conditions, healthy young adult, healthy children, and healthy elderly at the end of prioritization list. Based on this advice and also on the intention of the Director General, we worked with our colleagues from regional offices to come with criteria with eligibility and sequencing of vaccine deployment, but we also sought advice from the SAGE upon. And we started to work on a basket of principles that would define the sequence of distribution of the vaccine in the different countries. And this is not in any ranking order. So the first consideration was about vulnerability. So how much cases there are, what is the mortality, number of deaths in the countries, what is the perspective, other countries in the northern or southern hemisphere, have they already had a peak or not? And this was one of the important criteria. The other important criteria was about readiness consideration. Indeed, the last thing anybody would want is to have shipment of vaccine to countries and vaccine supply staying on the tarmac or on a warehouse unused. So readiness is a critical factor, and this is why what we are really working on very hard right now. So readiness has two aspects: the legal readiness, because the countries have to approve and to agree on the legal principle about waiving of liability, for example, and also about having in place an appropriate deployment plan, readiness for deployment. So this is why we are planning now to first deploy 2% coverage in 95 countries. You will have a list very soon. So this will require 36 million doses. And as soon as this is finished, and we hope to be finished, we started only in December and not in November as in this slide. But as soon as this is done, we want to go to the second phase, which is to top up and have all these countries have enough vaccine to cover 10% of the population. Where will the vaccine be donated? You can see the region, the WHO region, with a higher number of doses is the African region, indeed, because this is the region who has the less access to vaccine. Indeed, only two countries would have had access to vaccine should this initiative not been launched, and these are Algeria and South Africa. So a large proportion going to Africa, but you can see that all the regions of the WHO will receive supplies of pandemic vaccine, including, indeed, of course, the Americas. I don't expect you to read this slide, but you can see that there are 95 countries that are eligible for WHO pandemic vaccine support. I would like to point out that these are not, the characteristics are not only economical, because by the time we wanted to deploy this vaccine and we worked on this list, of course, economical reasons were important, because you need to have funds to buy vaccine. But we came also at the beginning of a pandemic in a situation where even with funding, you could not buy vaccine because simply all the books were closed. So with the regional offices, we worked closely to come up with a list which was based on economical consideration, but was based also on need. So this is why you can see that the list of eligible countries is much larger than the list of countries, for example, who has received oseltamivir from WHO. In terms of support, what needs to be done? Well, before a country can receive the vaccine, some key requirements must be met. So there must be a letter of intent that needs to be sent to WHO. The government needs to write to the WHO Director General and say, yes, I would like to receive vaccine. Nobody wants to push vaccine to countries who would not want to receive vaccine. Then there needs to be a signature of a contract, a formal agreement with WHO, which includes acceptance of liability for any rare adverse events or side effects. And as I said already, once submission of a completed, vetted in-country deployment plan with financial gaps covered. So the countries must also agree to ensure registration of a vaccine or to otherwise waive registration and authorize its use, to commit the appropriate and ethical use of a vaccine donation, to agree to handle the importation, to agree also to notify WHO and the manufacturers of any occurrence of unexpected side effects. Here is where we are in terms of a donation. So far we have 13 donor governors. Many of them have pledged vaccine, but some of them have pledged financial support. 5 donor manufacturers, 190 million doses have been pledged, as well as a little bit more than 74 million syringes, and $46 million have been pledged for operations. So if you see, I need to see this a little bit loud. No, I can't see it. You can see here that we are not quite there in terms of vaccine access, and some of vaccine, I must say, in addition, will come late in 2006. So we are still looking forward to receiving vaccine donation. But what is really starting to be critical is the amount of funds that we have to deploy this vaccine. Deployment of a vaccine in countries costs anything between $1 and $5 a dose. So you can imagine that to deploy 200 million of doses, this country will need a number of hundreds of US dollars to ensure that the deployment will be feasible. So this is really one of the resources that we are currently struggling with. What are the vaccines which will be donated and are donated to WHO? The types of vaccine are usually the typical vaccine are for 4 types: whole virus, split virus, subunit, and live attenuated. And we will be receiving from the 3 types on the right. So the split, most of it will be split, but also subunit and some live attenuated. What were the public, and still are in some arena, public concerns about the safety of pandemic influenza vaccines? So what we discussed and what we heard the most from journalists, from the press, from other stakeholders are fears about Guillain-Barré syndrome, based mainly on the episodes of Guillain-Barré following vaccination against swine flu in 1976 in the US. Many concerns also about adjuvanted vaccines, about the safety of adjuvant, in particular squalene, which is one of the components of the adjuvant, thiomersal, which is the preservative which is included in the multi-dose vials, as well as specific risk for special group and in particular pregnancy. So what is the safety? What do we know of the safety of pandemic vaccine in clinical trials? Well, we can really say that most of the evidence generated in the clinical trials, as well as what we know from H1N1 pandemic vaccine, is stated here that the profile is really similar to what we know from seasonal vaccine. So the profile of safety is a little bit different, with live attenuated in orange and in inactivated, but most adverse events are mild, and some of them are very common, some common, but really no concern for safety in clinical trials. In terms of real safety monitoring of pandemic vaccine in large-scale usage, you can see, again, there are too many countries of these slides, but you can see all these countries have started and have done mass vaccination campaigns. And you can see here in January, we have Azerbaijan, Afghanistan, and Mongolia starting deployment with donated vaccine, and Iran on vaccine purchased. In terms of safety, safety was reviewed by the Global Advisory Committee on Vaccine Safety early December, and really after more than 200 million doses of vaccine have been deployed, more or less what we can say is yes, there has been severe adverse events, but no more than what would have been expected. There is no concern so far of specific safety issues with pandemic vaccine. So in terms of recommendations, SAGE has reviewed in October a recommendation on use of pandemic vaccines, and this is crucial now that the vaccine is being deployed in developing countries. SAGE has said that in adults and in people more than 10 years of age, 1 dose would be sufficient. And in children less than 2 years of age, although many regulatory authorities do for certain types of vaccine recommend 2 doses, WHO has made a recommendation that 1 dose should be given to as many children as possible, because vaccine supplies are constrained right now, and potentially a 2nd dose when more vaccine is available. There is no concern about safety in pregnant women, and all the licensed regulatory vaccine, unless there is a specific notice from the regulatory authority, can be used in pregnant women, and vaccine can be co-administered with seasonal vaccine, unless both types are of a live attenuated sort. In terms of pre-qualification, all these vaccines are undergoing pre-qualification, which is a condition for deployment by WHO. You can see that many of the pandemic vaccines have been already pre-qualified. Sanofi Pasteur vaccine is pending pre-qualification because we are still reviewing their dossier on the seasonal vaccine. They have to respond to a number of questions posed by our WHO regulators, but we hope to be able to pre-qualify this vaccine very soon also. In terms of deployment, as you can see, 86 out of the 95 countries have requested vaccine donation. So the DG has requested them, the government, to say whether they would be interested or not. And you can see the overall majority have said they would like to have vaccine, and we are still following up with the 9 countries who have not responded. They have not said no, but they have not responded. 28 countries have signed the agreement with WHO so far, the legal agreement, and we can only deploy in this country because the legal framework needs to be in place. And in terms of national deployment plan, you can see that 9 countries have a complete and final deployment plan, soon to be finalized 24, and will take a few weeks to be finalized in 62 countries. In terms of deployment, these are the countries the most advanced. Afghanistan has a deployment plan now approved. They have already received the safety boxes, and the rest will be soon on its way to the countries. In Azerbaijan, the vaccine and all the ancillary equipment is in place now, as well as in Mongolia. In Sri Lanka and Ukraine, also material is moved to the countries to start deployment. Of course, vaccine deployment has been slower than expected. You can see by the end of November, mainly vaccine had been developed in high-income countries and some in middle-income countries. But so, of course, we would all have hoped that this would move quicker, but there has been complexity. So what were this complexity? There was a very tight time frame imposed by the rapid spread of a pandemic and the changing expectation of a population. And it's interesting to see that in different parts of the world right now, there is a completely different take of the population and of media on pandemic influenza vaccine and vaccination. Ad hoc negotiation, because there was no overarching framework. It was difficult for the manufacturers to match demand on the absolute scale and also as of needed scale. And also government needed to balance domestic retention of enough vaccine domestically and donation to support global solidarity. There were also extreme logistical and legal issues, the need for standard approaches. We needed to have a standard agreement with all countries. We could not have a legal agreement that would be tailored for each of the 95 countries. So we needed to have a framework that would be acceptable for all the countries and also for all the manufacturers and all the government donors. Communication, intense misinformation also campaign is going on in many countries of the world, mainly by some anti-vaccination group, and there was and still is insufficient funding for the deployment. So as my concluding remark, preparedness and what we started to do already over the past years, and as far as vaccine is concerned in 2006, preparedness was essential and significantly improved its response overall as compared to what in the past or what could have happened. But it's still incomplete with many gaps. The flexibility was and remains essential. There's no degree of planning fully anticipates reality, and we have to see now, in view of the evolution of a pandemic, where the vaccine should be given first and where we can wait a little bit for the deployment. And finally, the complexity of improving access to vaccine demonstrates the limitation of an ad hoc approach. And there needs to be a framework put in place, and this is one of the steps towards this framework for future pandemic, and this will be essential component of better preparedness. So with this, I thank you very much for your attention.